Good afternoon, everybody. Thank you all for coming to our Public Health Forum. We're delighted today to have with us Dr. Stefano Bertozzi, who is the Dean of the University of California, Berkeley School of Public Health. I could spend a long time talking about Dr. Bertozzi's bio, but he told me not to. I think Stefano is actually an unusual person who really has lived public health in multiple different places. He's been both at UNAIDS and World Bank. He's also been at Gates and also been in the academy. I think he really has lived the kind of public health that we talk about, where really he's produced scholarship and also seen that translated into the real world. I have been talking to Stefano and watching and learning what he's been doing at Berkeley with a lot of admiration. So it's really been terrific to invite him here today and to hear what he has to say. Welcome. Thank you for coming.
Thank you. Thank you so much, and thanks everybody for coming on a not very pleasant afternoon. I know some of you were over at Croy earlier. I'm going to start. Oh, if this will work. There we go. My third child is graduating from high school, and so for some reason that caused me to open up my high school yearbook and look at my senior page. And on my senior page was this quote, which I'll let you read. But it was interesting for me to go back and look at it, because I thought to myself, you know, if that's what I thought when I was graduating from high school, I'm actually reasonably consistent, because because I, as Sandro mentioned, I'm not really good at anything, but I know a little bit about a lot of things. And I've flitted back and forth. I've tried to be the doctor for the economists and the economists for the doctors and things like that. But it got me thinking, because we're in a world which is very, very different from the world I trained in. I trained in a world in which researchers were taught about collecting data, because data were expensive, and you designed studies so that you collected the smallest amount of data that you needed to answer the question that you wanted to answer. And now I find myself running a school in a world in which we're just swimming in data. And for those of us who work a lot in the developing world, it's not as if the developing world is somehow not swimming in data, and we are here. In fact, we're swimming in data all over the place. I think my next slide, if I can make this thing move. Oh, no, not quite. Oh, but that's right, because I have a little distraction here. So before I get to that of the developing world and the data, I have to show you this, because as I was thinking about this specialization thing, which has nothing to do with what I'm going to talk about, but I'll say it anyway, I thought, okay, well, just imagine what it costs to train an ophthalmologist to open his or her LASIK clinic and spend 8 hours a day doing LASIK surgery. I said, well, it would cost, about $10,000 when they're little, and about $40,000 a year in college at a public school, and about $100,000 a year in medical school and residency. And then after that, another $150,000 a year, the difference in cost of paying, at minimum, paying an ophthalmologist to run a LASIK clinic, as opposed to what it would cost you if you just had a doctor that was a LASIK doctor. That wasn't trained on everything from bunions to neurology, just trained on being a doctor for LASIK. And you could probably do that, take a smart kid out of high school, maybe they weren't super good at organic chemistry, not that that correlates with being a good doctor anyway, and train them in a year to be a LASIK doctor. And since in India they train people to do just as well as ophthalmologists taking out cataracts in that period of time, certainly you could train somebody to push the button on the LASIK machine. No disrespect intended, I don't know how actually it works, but I'm imagining it's easier than doing a cataract. And over the course of the life of those two people, there'd be a difference between spending $210,000 to create the LASIK doctor or spending $6.7 million to have the ophthalmologist doing that LASIK specialty. So the reason I mention that is because, if we're sitting there with this issue of specialization, probably none of us would want to be a LASIK doctor, and we're happy for the broad general education that we've gotten. And so I'm really of two minds about what this means in a world in which we start to have more and more data in which we can much more precisely do things and therefore potentially specialize much more. And so as I said, well, I'm probably not supposed to say anything impolite because I'm being recorded, so I won't. But this is the, when I say we're swimming in data and not just in rich countries, this is the cell phones per capita in just 71 countries. And you can see that, 4/5 of them have more than one cell phone per capita. including, a number of developing countries. Brazil is way up there at 1.3 or something to 1. So there is really no country. I mean, I complain a lot about cell phone coverage in Berkeley and Oakland because the coverage is better in the Serengeti than it is at my house. And it turns out, in fact, if you're in rural Tanzania, you need a cell phone more than you need one in Berkeley or Oakland because we can get a pretty good landline. And of course, anybody with a cell phone, there's data on who they talk to, who they exchange money to, if you're in East Africa, where they are, how often are they talking to people. There's just huge amounts of data. And if you're in East Africa, they even have banking information on you. So we are swimming in data because there are now very, very few clinics in the world, even if they don't have electricity, that don't have a cell phone. And that don't have the ability. I mean, I was in a clinic in Rwanda, no electricity, but the chief nurse, Mother Superior, walks to the top of the hill on her cell phone. She updates the supply chain stuff for the clinic and gets her ARVs from Kigali. And so it's extraordinary how we're now swimming in data, which means a whole premise of how we approach research and how important it is to be frugal in data has changed, and that's not a surprise for anybody. So I'd like to think of the world, being an economist, you can just make up data, so I'm going to do that. This is made up data, and it's just a distribution of population in some health outcome, doesn't matter what it is. And this is what the distribution actually is. And I'm going to suggest that this is a combination of two kinds of heterogeneity. Heterogeneity that's justified, because some people are short or small, or some people have certain genes and are predisposed to X, Y, or Z, and unjustified heterogeneity, which is the result of a poorly performing health system that's not getting the best outcome you could get, given that person's justifiable heterogeneity. So if you could eliminate that, then the distribution of outcomes in the population would look something like this. There'd still be some people with some bad outcomes, but all of those people who have bad outcomes because you didn't do the right things for them at the right time with the right instruments or tools or drugs or whatever, would be eliminated, and the distribution would look red. So to the extent that we have data that can help us understand where we are in this distribution and where we should be going, well, that can be super helpful, right? So obviously any of us who've been educated in this field have been seeing evidence of heterogeneity for a very long time, and this is one example. This is just coverage of antiretroviral therapy in Africa among people who have TB and who are also HIV positive. So there isn't a country in Africa that doesn't think that 100% of these people shouldn't be on therapy, and you can see that from country to country there's lots of variation. And I can't see it as well as you can, but it looks like Ghana's pretty bad and Ethiopia's pretty good. And that's useful and important information, but not so much in terms of actually what you're going to do about it, because other than saying Ghana, not so good, it isn't actionable in the sense that the manager of the clinic that's causing this problem doesn't know that he or she isn't doing a good job in the clinic. In other words, the granularity of this data from the perspective of how you might use heterogeneity to change practice and drive improvement, this isn't the right level of granularity. Unless you're going to tell me that USAID does its allocation decisions based on national performance, but they don't. So, or the Global Fund does, but they don't either, really. They might in terms of whether something gets implemented, but they're not going to do it on the basis of this. So my suggestion is that it used to be, we've had these kind of data for a very long time, but now we can have granular data because it's free, because it exists already. We're just, for the most part, not taking advantage of it. And what could we do with it if we did? Well, so instead of that level of granularity, this is the level of granularity we want. So Howard Schultz is the CEO of Starbucks, and I can promise you that he knows exactly what the revenue and the expenses are in every single Starbucks anywhere. In fact, he probably knows exactly how many pumpkin spice chai lattes they order in every different one. And with that, they know on a day-to-day basis which Starbucks should be closed, where there's excess demand, and others should be opened. And we don't have that even for HIV clinics, which are much more complicated and where it makes much more difference. People's lives depend on it. So if the level of granularity here, forget down to the individual barista, is to the level of this individual Starbucks, how is it possible we don't at least have production and revenue, production and cost information about every HIV clinic anywhere? And wouldn't you want to see how they compare, right? And to a very limited degree do we have that kind of data systematically. And that's surprising if you're trying to drive performance. So here's one example. This was before Eric Goosby left PEPFAR, so it's old data. But they went in and they looked at the clinics in Mozambique that they were supporting, and they said, what are the costs, not the drug costs, but all the non-drug costs of treating ARV patients in clinics in Mozambique? And in 2009, you can see the distribution there. And in 2011, they'd basically done nothing other than reveal the heterogeneity to the clinics. So here's where you are on the distribution, and let people sort themselves out. 2 years later, not only is the variance much, much smaller, but the mean is smaller, and in fact, the best performing clinics are performing much better than they were before. So this, I have to say, without that much evidence, I'm a very strong believer in the power of sunlight. And for me, this is just sunlight. Because it may be that every clinic had some sense of where they were, what their cost, they didn't even know that, to be honest, but even if they did, they didn't know it in relative terms, and even if they knew it in relative terms, other people didn't know it in relative terms, so the reputational issues and everything else, it didn't bring out natural human competitiveness and all of that. So here's a US example. This is cesarean section rates, and it varies from 7 to 70 in terms of percent of births that are born by cesarean section. And it's very hard to believe that this is explained by a difference in the medical situation of the women in these hospitals. Now, some degree, of course, will be explained by that. And something else somebody said to me was that a danger of a turnip graph like this was a new term to me, I didn't know they were called turnip graphs, is that somebody might choose to think that, well, the modal value there is a good one, and that you might get, what if 15 is the right answer, which is what people told me in medical school. I don't know what people are saying these days, but if 15 were the right answer, that would be the second one closest to the bottom, and that nobody should be aiming for that 32 level, even though that's what's most common. So the question, an important one is I just showed you heterogeneity, and in that first made-up slide, I said there's justifiable and unjustifiable, but it's not necessarily so easy to know the difference. What is the difference between justifiable and unjustifiable heterogeneity? And like most things in life, it depends. And what do I mean by it depends on your perspective? Well, here is, in our domestic world, one of our most important, if not our most important, and certainly among our most controversial correlates of heterogeneity, and that's race. So race, self-declared race by an individual, is correlated with many things. It's correlated with genetics to a degree. So if we were looking at sickle cell anemia, that might be useful. But it's also correlated with racism. But it's not just correlated with racism of one type. It's correlated with historical racism. It's correlated with housing covenants. It's correlated with racism by providers. It's correlated with racism in access. It's correlated with all kinds of different things, some of which are contemporaneous and some of which are historical and some of which are a combination of the above. So if you look at this one, this is a very recent article. It's 2016. You can see that unadjusted, the odds ratio of major morbidity after a coronary artery bypass graft is over 1.5. And then you can start to adjust for things, for other factors. And so the question is, what's justifiable and what's unjustifiable? So I think most people would agree that something that is genetic variability is, in fact, justifiable variability. I think most people would probably agree with that. So to the extent that sickle cell trait explains this difference in major morbidity, and to the extent that race is a proxy for likelihood of having sickle cell trait, most people would think that was justifiable. But I'm pretty sure that almost none of this variability or none of this increased odds ratio is a function of sickle cell trait, although I'm certainly no expert. So the difference between unadjusted and patient characteristics is things like obesity and hypertension and diabetes, all of which are also correlated with race. So is that justifiable or unjustifiable? In other words, is the correction there on patient characteristics a reduction in heterogeneity that we can explain, a justifiable one or not? Well, it certainly depends on your perspective. If you're responsible for the state health department, then the fact that African Americans have higher rates of uncontrolled diabetes is not justifiable, I would imagine most people would say. But if you're the surgeon doing the CABG, you might find that justifiable, because of course you'd want to be able to take into account the fact that your patients have differential levels of both prevalence and control of diabetes and complications. So it becomes very complicated, and that's why I say that what for the surgeon is justifiable is different than what for the hospital is justifiable, is different than what for the county is justifiable, or for our society more broadly, and it's not necessarily an easy question. That doesn't mean that revealing the data don't lead to better behaviors, potentially. And this is Washington, D.C., and it's HIV prevalence. So it's not results of something, except the results of decades of HIV prevention, or lack thereof. And the difference, this is, I mean, what I find amazing when you get micro and more micro data is it's, I don't know how many of you played with fractals, but fractals are these things that every time you blow them up, they're just as complicated as they were before you blew them up. So it's got like continuously similar complexity. So 2 orders of magnitude difference between one part of this very small city and another part of the small city is pretty amazing. I mean, it's as much heterogeneity as you see at the national level. It's more heterogeneity than you see from country to country, typically. And yet you're seeing it all within one very small diamond. Now, of course, I told you, and it says there that that's HIV prevalence, but that could be a map of many other things. It could be a map of diabetic control. It could be a map of poverty. It could be a map of race. It could be a map of all kinds of things. And however, having that level of detail, certainly if you're the AIDS program manager and you're distributing your resources uniformly across the census tracts in Washington, D.C., you'd be doing a really bad job. So I'm going to just use this little picture to think about what are the various pieces of things related to data that might be useful to us in thinking about unjustified heterogeneity. And the first of those is the fact that the data are usually existing in lots of places. And to be useful, they typically need to be pulled together. So I've been working for years in Mexico and was recently down visiting the Social Security health system, which is responsible for about 55 million Mexicans, which is about 5 times the size of Kaiser, which is the biggest similar integrated health system in this country. So it's huge. And they have lots of data. They have electronic medical records outpatient, they have electronic medical records inpatient, they have HR systems, they have management systems, they have supply chain systems, they have pharmacy systems, and none of them talk to each other. There's no way that you can link pharmacy records to EMR records to supply chain records, so you can figure out if the fact that you've got terrible viral suppression in one clinic has to do with the fact that they've got a supply chain problem, or it's the training of the doctors because the HR system has the training of the doctors, or the composition of the staff because that's a different system, or the budgeting, or whatever. So an ability to pull these things together is one really important skill, and it's not something that any of us are very good at. If any of you have the opportunity to watch Palantir, a company that has made itself very rich doing this, initially for things like the CIA, to see their presentation on what they've done for CDC, it's very impressive. And they have a little demo that they do sort of live in real time where they track salmonella outbreak in the Southeast and the Midwest, and it's very clever because they pull together information from where the cases are, with where the restaurants are, and what the chains of the restaurants are, and what the suppliers of the restaurants are, where the farms are, and bing, 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 they pull it all together because they're accessing everything from white pages to supplier databases to epidemiological databases, et cetera. So obviously, once you get the data in a form that you can use, then you'd like to do some descriptive analytics of it. And I'd argue, using sort of the examples like the Mozambique one that I showed, that alone, that sunlight alone, just the fact that there is variability, and here's where you sit on the curve, changes behavior, improves performance. I mean, just sunlight alone is a good thing. Now, so here's an example that many of you have probably seen. PEPFAR in Kenya used to distribute its resources to prenatal clinics relatively uniformly through the national program and other partners. And then somebody decided to look at where the women identified as HIV positive were coming from. And it turns out that about half the clinics in Kenya weren't identifying any, and that 90% of the women identified as HIV positive were coming out of 28% of the sites, which were overburdened, lines around the block, not able to handle the load, et cetera, because the resources weren't following the demand. And not having this information from the beginning suggests that somebody was thinking that Kenya's got a lot of HIV and it's relatively homogeneous, sort of as if assuming that Washington, D.C. was relatively homogeneous. And if you do that, you do a really bad job, right? And so I think that now the resources are better targeted. This is an example from Mexico. So this first one here, so these are all the clinics, 120 clinics that the Ministry of Health supports to provide antiretroviral care, which is now available free of charge for all Mexicans, but it's provided separately in the Ministry of Health system and in the Social Security system. So this is a measure of what proportion of patients in that clinic started their antiretroviral therapy above a CD4 count of 200. So if you want to start people above 500 and you really want to start them above 350 and you absolutely need to start them above 200, otherwise they get infections that kill them, these are the clinics that start, what proportion of the patients in that clinic started above 200, and you can see that it goes from 75% down to below 25%. So huge variability. And these are, it's not, there are only 120 across a population of whatever it is, 120 million. So it's not like there isn't sufficient demand or they're in some remote village or something like that. They're all relatively centrally located. There are only a couple per state, an average of 3 per state. And this, I think, is also, for me, just revealing this to heads of clinics. The first reaction, of course, is, well, that's not my problem, right? My responsibility starts when the patient crosses the threshold, and they get to me when they get to me. And, of course, it depends on your perspective, right? So from the perspective of most clinic managers, they think this is justifiable heterogeneity. This is the hand they were dealt by the community that they happen to be placed in. And so my answer to that is wrong. Right? You work for the National AIDS Program. Your job is to get people on treatment, not just to provide them treatment when they get to you. And so it's your job to figure out where they are and to work with your community groups and to make sure that people start treatment in a timely fashion. So this is a measure for me of the clinic's effectiveness it's a proxy measure of the clinic's effectiveness in getting people into care. Now I'll be a little bit fairer to my colleagues in Mexico to say that this is unfair because this is of everybody who's in the clinic. And in an old epidemic, at the very beginning, nobody knew anybody had HIV, and so people were diagnosed very late, and in fact, some people were diagnosed before ART was available, and so this is a little bit unfair. And what we should have is the last year, or the last 2 years, or whatever, but nobody, I think, is holding clinics accountable for this statistic, and we should, because it's highly variable. This is the same thing, same clinics, but stacked by the proportion of patients on therapy with an undetectable viral load. So this is a measure of how well the clinic is doing at suppressing viral replication in its population of patients. And again, the 2 clinics that claim to be 100 are clearly wrong, but you can see that there's a very wide distribution down to clinics that have about 35% of their patients with viral suppression, which is sort of like saying that clinic is a resistance factory, right? It's not really doing effective antiretroviral therapy. It's just creating expensive patients that will die much younger than they should. So if the first one is the effectiveness of reaching the community, the second one is the effectiveness of treating the people who are in the clinic, this one is a kind of a combined measure, which for me is, if our goal in treatment is to restore people to healthy immune systems, so our goal is to keep them alive and well, but if we're not measuring keep them alive and well, we can measure this, which is, have we got them virally suppressed and with a healthy immune system? And there you can see there's even more variability, because of course it's a function of the ones who start really late are less likely to have recovery in their CD4 counts, and the clinics that aren't suppressing viral load obviously can't suppress viral load and get recovery. So 3 measures here that should be measurable in any clinic in the world. I mean, even clinics that are not doing routine viral load testing on all of their patients, there's no reason they can't be doing a sample of viral loads to know how well the clinic is performing and what proportion of the patients in the clinic, some periodic basis, once a year or whatever. There's no clinic in the world that they shouldn't be able to generate these statistics for its patients and should know how they're performing, at least on the basis of these 3 crude, but I would argue effective proxies. When you translate that variability into costs, you see it has huge variability in costs. So you've got clinics that are effectively restoring people to health for a third or a quarter of what other clinics are doing. And we can't afford to spend 4 times the money we could get for a quarter of the money, and we could obviously do a whole lot more with PEPFAR's budget, or in this case, Mexico's budget, if we did it more effectively. So that's an example of 120 clinics. So this is the same country, same system, the Ministry of Health system, but this is actually supported by the Carlos Slim Foundation, and they said diabetes is now the #1 cause of morbidity and mortality in Mexico, which is pretty extraordinary. They've surpassed us in obesity. They're the #1 soft drink consumers in the world. 60% of the soft drinks in Mexico are sold by Pepsi and Coke, so we have a responsibility in this extraordinary level of diabetes. And it's amazing to me, because I go down for Christmas, that in the Christmas movies for the kids, Santa Claus is still pushing Coca-Cola to kids in the movies. So for me, it's the equivalent of pushing Marlboros on 10-year-olds. But what you see here is a dashboard that was created. Now, this is a nominal dashboard. It goes down to the level of the patient. It's only for 4 diseases, or 4 diseases in quotes: diabetes, hypertension, obesity, and dyslipidemia. And right now, it covers almost 12,000 health centers, upper left, and has almost 1.4 million registered patients. And what you can see here is that of the almost 800,000 patients with diabetes, less than 15% of them last year had measurement of their hemoglobin A1C, which is what you expect all patients with diabetes to have, because it's the measure you want to use to look at their glycemic control. So that should be 100%. It's less than 15%. And of the ones with measurement, 37% had a hemoglobin A1C of less than 7. Now, 7 is a pretty strict level. I mean, the number I have for Kaiser is 8. But still, you can see that less than 40% of 15% who were even measured. But huge variability. That's Mexico. That, of course, is 5.3% documented control, right, of a population. Now, mind you, this is the #1 killer in Mexico, in a country that has really effectively reduced its diarrheal diseases, respiratory diseases, one of the best vaccination rates. I mean, it's not a country with a falling apart health system. It's a country with a falling apart ability to deal with chronic diseases in their health system, but not a health system that doesn't exist. It now has universal access to health insurance. The reduction in uninsured has been more dramatic than the ACA. Here you see one clinic in Mexico City. So instead of 15%, they've got about 50% of their patients with A1C measurement and better control. Here you see a clinic in Juarez where less than 10% even got measured, and less than a third under control. And here you see the state of Tlaxcala, which looks almost like the country. And just to repeat what I said about every time you open it up, you look one level down, it looks just as heterogeneous. So you look within Tlaxcala, which looks just like the country, but within Tlaxcala you have clinics that are measuring 75% and many who are measuring 0% of their diabetic patients' A1C. And there you can see that at 5.3 at the state mean, and Kaiser Permanente, Northern California, at 70% at a hemoglobin A1C of 8. So similarly vertically integrated healthcare system. And the difference is that what Kaiser does is it actually pays attention to the data down to the level of the provider and provides that feedback. And it's not a surprise, they perform a whole lot better. So, by the way, I didn't say at the beginning, I think we've got a fair amount of time, and I'm boring if I keep speaking. I would love to be interrupted, and I know that BU is not shy, so please raise your hand and interrupt me. Tell me when you disagree with me. It'll make it more interesting for everybody if you do. No reason to have to wait till the end. I don't mind being discombobulated. Please.
I think one of the challenges with these routine data sources is that it's very hard to interpret the rightmost column, the proportion suppressed, when the proportion screened is so variable. I'm just curious in your thoughts about how to resolve that conundrum.
Well, it seems to me that at a minimum, the proportion screened and suppressed, the proportion of the screened who are suppressed is almost certainly an upper bound for the proportion of the unscreened suppressed, right? The likelihood that physicians are doing a better job of glycemic control in the patients in whom they don't even measure their glucose than in the patients that they do would be a hard case to make, right? So, however, I completely agree with you, it's not zero, right? The question is, what is the interaction between those two terms? And I think the other part that it says is that the government is providing free hemoglobin A1C tests with universal health coverage for hemoglobin A1C and diabetic control. And the system is testing 15% a year. You know, that's pretty bad, right? And the thing is that if you just leave it at the level of the system, nobody feels responsible. So the question is going to be is that as these data are revealed, and not only can somebody look up where they are, but they can look at it comparatively, and that's frankly not live yet, but it should be live within a month or two. That graph of Tlaxcala, I did because my RA downloaded the individual data from all those clinics in Tlaxcala, and I picked a small state so it wouldn't be too big a job, and said, I want you to show me the variability, the comparative variability within a state. But pretty soon, anybody who runs one of those clinics will be able to go in and see how they're doing comparatively. And I'm suspecting that things will improve, but we'll see. Please.
Steph, I actually was curious about what you just said to Jacob. It kind of assumes that the screening, that the measurement of, in this case, HbA1c or anything, is random, and rather than the clinicians actually using judgment to decide who they screen. So that if they only screen the patients they think they have a problem with, then you could have worse outcomes in the patients they screen, right? I mean, I think we do see that when in the HIV setting, where we have worse viral suppression the more we look. Is that true, do you think?
Here, I don't think it's true, but it certainly is possible that it would be true, no question. Here, I don't think it's true because it's, it's complicated in so many ways. I mean, part of the problem is that Mexican clinics don't have laboratory capacity. So they're not internalizing the testing. And as we get point-of-care testing, this may change quite a bit. I don't know of any suggestion that in the case of diabetes, that what's happening is that patients are coming in and saying, you know, my sugars are out of control, I can't control them, and the doctor says, oh, we better check an A1C, and finds out that they're in poor control. I think it's more likely, and if anything, to be the other way around, where the patient's saying, I'm doing everything you told me to, or whatever, and very few people are checking their sugars anyway, even spot sugars. And the doctor is saying, well, I need an objective view of how well this patient is controlled. So I think unlike viral load, where you're more likely to get a viral load when the patient is not doing well, in this case, I wouldn't imagine, but this is my gut talking. It's not data. So I think both hypotheses are perfectly plausible. This bar here says that, it's a little bit answering what Jacob and Sydney have just alluded to, which is that we know more than just the one thing, right? We have lots of patient characteristics. We have lots of information about what's happening with the patients. So, it would be, if you saw a patient where the doctor had been chasing the hypoglycemic agents all over the map in terms of dose, and that was correlated with getting a hemoglobin A1C, then that would support Sydney's hypothesis. And if it was the other way around, then it wouldn't. So we have lots of information already in the database that we could use to get a sense of that. So the question of how can you be smarter about your analytics, how can you look at the determinants of that heterogeneity that you're finding and tease apart what you might consider to be justifiable or unjustifiable heterogeneity, and actually also start to use these systems for causal inference, I think that starts to be obviously more exciting and more useful. I almost hesitate to say that because I think that we so little use sunlight on just the basic raw data that can be so powerful that it's almost like we shouldn't say anything more than that. Just like, for God's sakes, do that. And then get rid of all that unnecessary heterogeneity that goes away just with sunlight, and then let's start to be even smarter about figuring out how you do the rest of it. But of course, we can start to do the rest of it right away. And so this was, it looks like a no-brainer, right? This is all good. But what if this distribution of costs was actually perfectly correlated with quality, right? What if we actually, by revealing this heterogeneity, got rid of all the high-quality clinics because they stopped spending money on what they needed to do to get quality, and now they're all uniformly low-quality clinics at low cost, right? So that's a good question. I don't have the data from Mozambique, but this is a different study that Chai did in Rwanda a little bit before. And this is cost of care in ART clinics in Rwanda, and they're divided up by those that have international support and those that don't. Obviously, most of them do. And you might ask yourself, this is a big difference, right? There's more than a twofold difference in cost of care across these clinics. And how does that correlate with quality? Well, I only have one measure, and that one measure I have is just retention, which is not a perfect measure, and people here can give me a lecture on that. But if we just use that one crude measure of retention, we would see that there's zero correlation with cost. So the lowest cost clinic on the right-hand side kind of ties with the best retention, and it bounces around, but not in any predictable way. So it would be hard to say that we're getting our money's worth in the high-cost clinics, because we're getting, in fact, it would be even hard to say, with the exception of that very first one, which looks a little bit worse, but with the exception of the very first one without international support, you couldn't even say that international support seems to be correlated with retention. But so that's just to say super crude, but important to know what you can correct for and what not. Here are two other examples. So on the left is voluntary counseling and testing. On the right is prevention of mother-to-child transmission of HIV. These are 4 countries in Africa: Kenya, Rwanda, South Africa, and Zambia. And the x-axis is scale of the clinic. How many people do they see in a year? And the vertical axis is cost. And the lines, the sort of regression lines that are drawn there, reveal what a good economist would expect, and that is that there's a relationship between cost and scale. There are economies of scale. But that, of course, is not the message on this slide, because the vertical axis and the horizontal axis are both log scales. So what you see here is that at any scale, there are 2 logs of difference in cost, from the lowest cost to the highest cost for either of these two services. Now, you might imagine that if these were CABGs, that might make sense. You have really simple patients, really complicated patients. These patients on the left come in, they get pre-test counseling, they get a test, they get post-test counseling, and they go home. I mean, this is as standard a health intervention as you could get. Like, nobody bleeds out during VCT, right? And PMTCT is pretty much the same thing. Like, of all the things we do with drugs in AIDS, it's pretty standard treatment, right? You can't expect a 100-fold difference, or even within country, more than a 10-fold difference in cost from one place to the other. So it's hard to believe that any reasonable portion of this heterogeneity is in fact justifiable heterogeneity. And this is important because I think that we've seen much more progress in HIV on the treatment side than we have on the prevention side. And that's because we have limited resources, we have excess demand for treatment, and so people have been forced by the very dynamic of the system. It's not quite private sector incentives where you've got profit, the dollar bottom line, but if you've got a line of patients out the door who are waiting for treatment and you can't give it to them, and you can figure out how to do it more efficiently, you can treat more patients and you can keep more people alive. And if you don't, they're upset about it, right? Same pressures don't apply in prevention. So you can run a clinic, you can staff it with counselors and laboratory technicians, and 2 people a day come in, and if you just keep getting your check, then you're up at the top of that cost curve. And similarly, if you do it efficiently, you're at the bottom of the cost curve. And that same pressure doesn't seem to apply. And I would be more optimistic if this was a one-time thing and we knew that we were on the right trajectory. But we actually did almost exactly the same study 10 years earlier, and we had 2 orders of magnitude of variation. There's no evidence over those 10 years that we've gotten better on the heterogeneity of cost for simple prevention efforts. And that suggests, now, I'll give Debbie Birx, this is the beginning of Debbie, this is not post-Debbie, so I'll give her the benefit of the doubt, and I do think that they're paying a lot more attention to these issues during her time at PEPFAR, and I strongly suspect that things have improved, but it's hard on the prevention side if you don't measure. If you don't measure what it costs and what the productivity is of each unit that's doing it, you're back in the realm of where Howard Schultz would never operate a company. Please.
Sure. So, in making your case for the potency of sunlight, as you say, I do wonder whether you're cherry picking your examples a little bit.
Of course.
Because
I'm giving a talk.
Because I think the examples you give are examples in which the behavioral response on the part of the clinic and the sort of the moral mandate is very clear. And when we're thinking about the science of how to make that mechanism work as well as possible, we also have to struggle with clinical settings in which the systems, the microsystems, are having to respond to multiple different stimuli, not just one about increasing the rate of antiretroviral treatment, for example. And often we overwhelm our systems with data feedback about all kinds of different performance indicators.
I completely agree. And, you know, the old management adage that if you can't measure it, you can't manage it. The other one is be careful what you measure, right? And there's no question, and we've worried about it since the beginning of antiretroviral therapy, that everything else in the clinic could go, you know, could fall through the floor because of the attention we put on one thing and the money and attention we put on it. So I worry about that. I think that the evidence in HIV has been that it's tended to raise the other boats rather than drown them. So I think that many of the early concerns were unfounded. And no question that you pick an indicator and it's going to be imperfect and it has the potential, and probably will, drive perverse behaviors, right? But the difference, I mean, if you look at this and you think to yourself, how perverse could it be that you look at cost per patient in a clinic, in a VCT clinic? Or how is it possible we don't actually fund it on the basis of, well, in my case, I go one step further. I see no reason to fund clinics to identify people who are HIV negative. So I would just set up the whole program to fund the identification of HIV positives. You would see a very dramatic response. There might be some perverse responses there. But the actual cost you care about here is not the cost of doing the voluntary counseling and testing. It's the cost of identifying a positive person and getting that person effectively linked to care. And if that's what you were actually paying for, it would change. Now, we tried to do that in China when I was at the Gates Foundation, and we got some perverse responses of people, you know, becoming identified more than once, and you have to be careful. And but so I take your point. I think it's a very valid point, and you have to be careful what you measure. I think that we're at the point, though, where we could go a whole lot further in the direction I'm suggesting, cherry picking acknowledged. So one thing you might say here is, well, maybe the quality is actually a function of scale and sophistication. We know that people who do more cabbages do better cabbages than people who do a few of them. But in fact, I didn't say it the first time, but these bars are proportional to size. So the only one I know for sure is Mexico City, because that's the big, huge, thick one. But there doesn't seem to be any relationship between where you are vertically and the size. So it's probably not size that's the major determinant. And at the same time, this is a relative, you know, it's only 120 clinics, and I'm looking really only at one service. This is not very complicated. This is way more complicated. These are clinics that are providing the full range of services, even though we're only measuring 4 of them. And there are already 12,000 clinics, and there are another 12,000 in the Social Security system. So I'm going to very briefly, and I'm going to jump over the slides here to the last one, make a pitch for some work that some of my colleagues are doing, and I wouldn't be surprised if some of your biostatisticians are doing similar work, which is, so parenthetical note. So I've spent much of my professional life looking at the impact of big health and social programs, much of that in Mexico. And I'm you know, as I said at the beginning, I'm a pseudo-doctor and a pseudo-economist. And so I'm the kind of guy who's, you know, I think I'm pretty good at figuring out what the experiment should look like. I'm not the right guy to ask to advise on what the specification of the best model would be to estimate that impact. So I get my buddies, you know, famous econometricians to come in and help us argue over the specification of the model. It's hard because you get 10 econometricians and they give you 12 models. So it's not obvious what the best specification is. And of course, if the one that you pick ends up not showing what other people think, then they're going to come back and publish a paper 2 years later using a different specification and showing a different result, and then you'll argue about whose specification is better. It's a hard thing. And it's a hard thing in particular to expect lots of people to do sophisticated impact evaluations because they don't have access to the same econometricians I do. So there's a limit to how well that stuff scales up. And the work that some of my colleagues, led mostly by Mark van der Laan, but a number of other colleagues, Maya Peterson, Alan Hubbard, are doing is using machine learning in a way that not only does what Walmart does with machine learning, which is fabulous prediction. So Walmart's really, they care a lot, and Google cares a lot about putting the best ad in front of you, as in the ad that's most likely to make you buy something. And they're very good at predicting what that best ad is, and they do a lot of machine learning to do that. it's not as helpful for us because we don't just want the best prediction, we want confidence intervals, right? We want to be able to say that if you have this surgery, the likelihood that it will help you is, this estimate bounded by something. So what they've done, and I'm going to skip over all these slides, but these are slides from Maya, which I'll leave you in the presentation. But basically, you can choose from 1,000 different specifications, a competition of algorithms, as she says. And what this super learning does is it basically uses the computer to look at all possible combinations of algorithms and choose the best mix of models that you might want to use for estimating your effect, whatever that effect is. Now, why is this approach really powerful? It's powerful for different kinds of people. It's powerful in the classical clinical trial sense, because if you're doing a clinical trial for the FDA, then they're going to force you to specify your model before you do the trial, because they're very worried that you might change the specification of your model to suit your hypothesis, or the drug company in that case. So they force you to specify the model ex ante. Then you do your trial, and then if it turns out the data don't come out the way you thought they were, right? Instead of looking linear because you'd specified a linear model for some parameter, it looks like two linears, right? With a big spline that you want in there, but you can't change your model specification. So it's a problem because it means that you then analyze the data with a suboptimal model, even if you were only using one. If you do the kind of work I do, where you're taking, let's say impact evaluation data in Mexico and looking for the impact of a program, then the problem is the one that I mentioned before, is that you can kind of pick your model to suit your results, and that creates huge publication bias and all kinds of things that we know is bad. So what this approach does is it specifies ex ante how the black box is going to work. You're going to throw 1,000 algorithms into it. It's going to optimize based on the data. It's not going to optimize based on showing your hypothesis to prove your hypothesis, right? And that has actually turned out, even for the FDA, to be an acceptable approach, although because it enables adaptive trial designs in a different way. I think this is a very exciting area of biostatistics because it democratizes potentially how many more people can do sophisticated analyses because they don't have to know how to pick the right specification of the model. So just this for me is one area where we're taking the huge amounts of data that we have with very limited analytic capacity, but potentially relaxing some of those constraints. And here's just one example from one of Maya's papers, Mark's, just demonstrating that this competition of algorithms produces the best predictor. So this is a short way of saying that if before just sunlight with an unsophisticated analysis of the relationship between whatever whatever's determining the heterogeneity and performance, if you include in that the things that may be justifiable or unjustifiable, right? But in addition to that, information on which of the determinants are best correlated with the unjustifiable heterogeneity means that if you're a program manager, you can attack the specific determinants more selectively and be smarter about how you address the unjustified heterogeneity, or justify the justifiable heterogeneity, right? Which is, of course, the whole case mix issues that this country has wrestled with ever since we started comparing mortality rates in hospitals and things like that. And I think that the tools are getting better to enable that, not only here, but also for developing countries. Also, there was the implication in your question earlier, is that what you might do about it isn't just sunlight. You might actually change some structures and mechanisms, things like pay for performance, or performance management, or HR policies that are aligned. I mean, there are things that you can do to innovate within the system that isn't just revealing. And if you do that innovation, you can evaluate and use the tools that I just talked about in evaluating those. And that's another area that I think is so exciting about this ubiquity of data. It used to be, so when I was responsible for the evaluation of Oportunidades, which is this big conditional cash transfer program in Mexico. And we started off the program, it started before I got there, with 500 plus communities. We randomized them to treatments and controls. We rolled out the program initially in those communities, and we kept the controls for as long as we could, well, which was just under 2 years, and then they were rolled into the program. And we mounted a hugely expensive data collecting operation to do that. And then as the program rolled out, we kept doing these evaluations. We'd go out, I'd send my teams out, we'd do household surveys, we'd do clinic surveys, community surveys, and we ignored what soon were 25 million people's worth of administrative data. Because That wasn't our data. It wasn't well controlled. It wasn't quality checked, et cetera. Now, in retrospect, I just feel like an idiot about that, right? Because rather than tackling the challenge and the opportunity, it turns out when you have data on 25 million people, you can handle data that's poorer quality because you have data on everybody. And you can, you can take a quarter of the data, and it's still way more than you had in your experiment. I mean, it's, and that's obviously what the Walmarts and the Googles and other folks do. And I think that this is a fundamental thing that we need to wrestle with in the academy, because we train our students that any conclusion that we're not 95% certain of is worthless, right? And then we send people out in the world, and many of them go and manage health programs, and maybe 5% of the decisions they will make with 95% certainty. So most of the time, they will be making decisions based on less than 95% certainty, and yet we don't teach them how to use information that's less than 95% certain, and we tend not to teach them how to work with messy data. So the cool thing in a place like Oportunidades right now is that if you were to roll out a new version of iron sulfate for prevention of childhood anemia, and you did that just by being intelligent about which are the first 100 clinics that are going to roll out the new anemia, and you just followed the administrative data, you could learn a huge amount about the effectiveness of that, and it wouldn't even be research. Right? It would just be smart implementation. It would be using the management tools that any normal system should be using to monitor its performance in reducing childhood anemia, if that's one of the main goals of the program. And you basically can experiment in what is a cohort of 100% of your population. So Kaiser has 11 million patients. It's starting to think about how you actually, instead of creating a cohort, how your cohort is your population, because you have electronic medical records. Every single Kaiser clinic and hospital is using Epic. They're all in one system. So I think it's a different world, and it requires some different approaches for teaching. And of course, if you do that innovation, you can improve performance. And I will jump super fast on the last thing, which is that some of the bad performance that we see is not just unjustifiable heterogeneity. It's that there's something wrong. There's a bottleneck. There's a structural problem that's fixable. It may be fixable with a new technology or a new procedure. And if you fixed it, whatever the curve is, you could just move the curve, right? And we're always trying to do that. That's what innovation's all about, right? And so an example, and I'm calling those structural or process barriers or whatever, and since I was driving, I had a driving thought, and I thought, this is the example of the unjustifiable heterogeneity. So you have justifiable and unjustifiable heterogeneity from one toll booth connector to the other. And imagine that the yellow is hour to hour the same collector, and the blue is booth to booth. And you'd say to yourself, well, if that yellow can maintain that level of homogeneity, then there's no reason why the blue should be that variable. And if you were the manager, you would step on the low ones and figure out what the high ones are doing that's smarter than what the low ones are doing. But more complicated. What if we were looking at average highway speed and this car is accessing the highway?
Can I take you back to what you said about the administrative data? I mean, do we not you made the argument very bluntly and said, we look at administrative data, but have we not struggled tremendously in Mexico with the recording of administrative data and what variables are recorded? From the experience of medicines, many variables that you would like to look at are not recorded.
Exactly
and moving or changing behavior of people and saying that needs to be recorded has costed, 7 years of work. And at the end, when it's recorded, it's not well enough recorded, etc. So I like the argument. I think there is a lot of value, but I think then also we need to teach the students how to, or which variables really matter, and how they need to be collected and embedded in administrative systems.
So I completely agree with you, and I was waiting for somebody, I'm not surprised it's you, to bring up that point. I think in general, if the data are just being collected to satisfy the bosses, they're going to be terrible quality, and they're not going to be useful, right? If the system is not feeding it right back so that it's useful at the level of granularity where it's actionable, you can force it, you can punish them, you can incentivize them, whatever. You're not going to get the right quality data useful if it's not fed back to the clinic. And so if you've got administrative systems that are not used for administering, they're used for reporting, then you've got a problem. I think that if you have a system which is monitoring diabetic control and it's at the clinic and it's drawing it's getting the download from the hemoglobin A1C machine, and that's an audit function that's able to be used, and it's the same data that's used to manage the patients. And then you start to have something that's useful and where the quality progressively takes care of itself, especially if the outliers then draw attention, because people want to figure out, why is this one so good or why is this one so bad? And if it turns out that the good ones are actually fake, and that's not good for them, it's those kinds of feedback loops. Otherwise, I think you're exactly right. I mean, I always say that people publish data on syphilis prevalence rates based on reported syphilis. I'm like, what, 0.5% is reported, and if someplace reports 2%, then it looks 4 times as big. I mean, it's like, it's completely imaginary data, right? So why do it, right? So I agree with you. So please.
Hi. I have a question regarding the quality of the data and the sampling. I understand your point that we need to believe on the quality of the data, but what about sampling error? And one of the first stories that I learned as a biostatistician was the 1936 presidential election, where you had a small company called Gallup. They sampled 1,000 people, and you had Literary Digest. They went out and asked 2.5 million people, and Gallup, they did statistical techniques, and they sampled a random sample, and they got a better prediction rather than 2.5 million people. So it's not always that more data is better.
Agreed.
It's how you sample the data. And where do you think the statistical knowledge fits into this big data paradigm that it seems to be?
And the last thing I'm going to do is to debate a biostatistician, because as I mentioned before, I only know a little bit. But what I would say, though, is that in many of these systems, increasingly, more so in middle-income countries than in low-income countries, obviously, it's not a sampling issue, because you have the entire population. So nobody in Oportunidades gets a check if they're not in the system. And they're not in the system if they haven't had a survey which is assessing their socioeconomic level. And they don't get their check if they can't corroborate that they're complying with the co-responsibilities, so that the kids are going to school and they're going to the clinic to get their health checkups. So the data may be poor, they may be cheating, they may be faking something, but you don't have a sampling issue. And the same thing, in a sense, with the EAMS, where it's an insurance scheme where you don't get treatment unless you're a member, and you're only a member if you're in the system. So I think that the more that systems become comprehensive, the less that particular problem is a concern. Obviously, the Reader's Digest famous example, which I actually had even heard of, is, I think it was Reader's Digest, wasn't it? I think it was Reader's Digest. That's very different, right? That's the equivalent of the difference between a household survey and a voluntary internet poll promulgated through Facebook, right? I mean, just to take an extreme example nowadays of representativeness. So, point super well taken, please.
You've described the use of data from unified systems. But
Yeah.
what if you have a system that's not unified? And a good example would be if the HIV clinic is seeing people come in with low CD4 counts, but they're not responsible for going out in the community and doing the screening, they can't affect that. And if you have a decentralized health system, shining light on it won't cause the effect. And my question is, can you build this sort of structural problem into your modeling? Because otherwise you may come up with results that aren't actionable.
No, I agree. And it can be tragic without mentioning which of the PEPFAR contractees, but I was once with a PEPFAR contractee that was very proud of having done 400,000 HIV tests in a particular country. And I said, really? And I said, and what proportion of the positives were effectively referred for care? And the answer was, I don't know, that wasn't our contract. And I said, oh, great. So why are you proud? And so what you mentioned is, of course, incredibly important. And I think that those are the macro management issues which we absolutely have to address. And it's a lot easier in a lot of developing countries than it is in this country, because I don't know of any country that's as bad as this one in terms of fragmentation like that, right? And we've just tried within California to look at performance of health plans on diabetes, hypertension, and stroke. And that alone has been a Herculean effort to compare health plans on those indicators. And that's why I have a number for Kaiser Northern California. But to look at that more comprehensively is really difficult. And you know, we're fighting in California for a single payer database, but even that we don't have. And there's, you know, a lot of what I would call intentional opacity, people who have no incentive to be transparent.
Thank you. So, you know, you're talking about getting good data to inform decision making, but certain things like this idea of a moral imperative or putting sunlight on the fact that one clinic is 15% and another is 75%, but what's the real driver for change at the unit of change? So the clinic could say, yeah, we're like, why, you know, they're 15% and somebody else is 75%, but what's the driver that says, yeah, I want to be 75%? This moral imperative, is that making a certain presumption about buy-in?
Well, I mean, what I was trying to say before about the power of sunlight is, let's at least release the power of sunlight. That takes care of X% of the problem, right? In the Mozambique example, it may have been sunlight, it may have been Eric Gooseby calling them all together and whacking them upside the head. I don't know. But sunlight itself has some measure, right? And beyond that, that's where I mentioned the issues about innovation, right? If the culture alone won't drive addressing that unjustifiable heterogeneity. So we seem to be nationally uninterested in addressing the very well-revealed unjustifiable heterogeneity between health outcomes for African Americans and Caucasians, right? We don't need a whole lot of additional data to be convinced that this exists. And we've even done lots of studies showing that it exists in specific institutions. Now, what I don't think we have is a ranking of institutions for where it's better and where it's worse so that they could feel competitive about it. And I think that that's something that we need, because otherwise we all sit there, you know, everyone sits there and wrings their hand and says, isn't this terrible? As opposed to saying, well, you know, in my clinic, that isn't the case. My CABG outcomes are not different. Now, sample size issues, is the population large enough? All kinds of concerns, right? And maybe you can't do it at the level of a hospital, but maybe you can at the county level or whatever. So, I mean, the economist in me says, and you can tell since I worked in Mexico on oportunidades, I think cash incentives are very powerful. I worked on the Rwanda program. They made a big difference. So sometimes when you tie people's livelihood to performance, that works. But there are lots of other things. I mean, somebody told me today, they're talking about Mayo, and I was talking about, you know, incredible performance in Rochester, Minnesota. I mean, it must not be easy to get people to move there, with all due respect to colleagues in Rochester, Minnesota. And the answer was, it's because it feels like a cult, meaning the culture is so strong from the CEO to the lowest level provider that what they do is excellent medical care, that their culture is really powerful, and they probably don't need conditional cash incentives. But, you know, so how you mix that up, I think, very good question. I'll show you this example and I'll shut up. This is a made-up example, in case you guys can't tell the difference between my made-up examples and my real ones. And I have no idea what the real relationship is between volume and highway speed. But I'm convinced that when you start to pile in cars into a highway at the beginning, they all go at 75 miles an hour, and then they start to slow down, and at some point it becomes gridlock and they stop, right? So it must look something like this, right? Made-up graph. And if you were the manager of the highway, well, you might let it get to that point, because at that point where that tangent hits the curve is where letting any more cars on makes everybody worse off, because it just starts to gum the thing up. Up until that point, the additional cars compensate for the slowness, right? So you get more people moved up until that point. So this is, for me, an example of a structural problem, right? This isn't that 1 kilometer of the highway is more or less better performing than another kilometer of the highway or toll booth or whatever. This is a structural problem, and in fact, we came up with a clever idea. I didn't, but somebody did, and that's metering lights, which all of us hate. But if you think about it, what they do is they prevent the highway from tipping over that tangent point to where everybody goes slower. So the fact you have to wait at the metering light means that you ensure the flow doesn't gum. And that's a really smart innovation. And if it turned out that primary healthcare clinics need to schedule fewer patients in January because it's flu season, and the drop-ins gum up the system, and therefore you need to change your scheduling, that's the kind of structural innovation which might not come out of the revealed heterogeneity. Or it might be that your HR system prevents you from moving people to one place to another without XYZ, and that means that you can't be flexible in your labor utilization, or whatever. And I think that these kinds of things, there are lots of approaches to it, and there's lots of innovation that can happen to respond to those structural barriers, and this is design thinking out of Stanford. I'm sure you've got people here on the faculty and the students who are doing design thinking, and I would love to talk more about it, but I don't understand it very well, so I won't. This is Six Sigma, which is something else that a lot of your management geeks have probably known a lot about, and I would talk more about it, but I don't understand it very well either. But the whole idea is that there are structured approaches to looking at gummy problems and innovating around them, and those should be applied. And that improves performance too. And the reason why it's relevant to data is that these same data, these system data that I was talking about before, can help to reveal. So if it turns out that what you see is not so much variability from clinic to clinic, but variability in day of the week, or variability in January and February, and that's correlated with influenza, or if it's a different time of year, it's correlated with rotavirus, that would be really useful information. So to summarize, we've got this issue of unjustified heterogeneity, the possibility of structural issues which create innovation and move the curve, and relating them all together, going back up to the top with this very considerable challenge of relating the databases, because I'm right now in Mexico, I'm in the middle of that problem, which is convincing the bosses of the systems that it's worth investing the money to relate those databases and enable them to be analyzed. And one of the things I'm suggesting to them is that everybody, every health system everywhere, not just this country, is very worried about letting outsiders into their data. So talking about, is it possible to create this thing, which is interrelated, and then to create what I've been calling a service firewall. So instead of having a firewall that just keeps people out, have a firewall that analysts can bring their questions to and their code. The service firewall runs the code and brings you back the answer without revealing the data to you. I mean, is there a way to get a much better connection between what academics can do and what students can do and theses can be written on, and these extraordinary data sets that we're not currently utilizing? And that's it. And so I still don't know what I think. I've got this cognitive dissonance. I was brought up Catholic, so that helps because we're better at that. I don't know what it says about specialization, because what it definitely says to me is that I call this precision public health. We've got to do a better job of the right things for the right people at the right time, but that doesn't necessarily mean that we create widget people who just do one thing. And figuring out what the balance is between how we adapt our human resources and therefore what we do in schools, in training, is for me a very tough question that I think we all need to wrestle with. And I am of two minds, although my heart is clearly here. Thanks very much.